Right now, I'm going to introduce, we have today Dr. Aliya Sarwar. She is a triple board certified neurologist serving as director of the National Parkinson's Disease Research, Education, and Clinical Center and director of the VA Post-Residency Advanced Fellowship Program in Parkinson's Disease at Michael E. DeBakey Veterans Affairs Medical Center in Houston, Texas. She is also an associate professor of neurology at Baylor College of Medicine. Dr. Sarwar received her medical degree from Dow University of Medical Sciences. She completed her neurology residency and sleep medicine fellowship at Baylor College of Medicine and her movement disorder fellowship at Michael E. DeBakey Veterans Affairs Medical Center. Dr. Sarwar has been part of several medical publications. Her research interests include neuroprotection, movement disorders, and sleep medicine. Thank you so much for being with us today, Dr. Sarwar.
Well, thank you very much for inviting me, and thank you very much for this gracious introduction. I'm really happy to be here today. So, as we know that I will be talking about the essentials of medical management in Parkinson's disease. I don't have any relevant disclosures. And the objectives of the talk would be to go over the rationale of the use of medications in Parkinson's disease. And in the process, we'll go over various medication options that are out there for symptomatic management of Parkinson's disease. And we will also go over a strategy to optimize the medication regimen in Parkinson's patients. As we all know, that Parkinson's disease is the second most common neurodegenerative disorder in the world. It's mostly known by its motor symptoms that consist of tremor, slowness, stiffness, problems with walking and balance. It also has a whole host of other non-motor symptoms that consist of problems with sleep, memory, mood, smell, bowel function, bladder function, sexual dysfunction, skin-related changes, and vision-related issues. Unfortunately, approximately 10 million people worldwide are living with Parkinson's disease. In the United States, approximately 90,000 cases are diagnosed each year. And now a little bit more than 1 million Americans live with Parkinson's disease. Men are 1.5 times more likely to have Parkinson's than women. The main problem in Parkinson's is the progressive dying of cells that produce dopamine in a part of the brain that is called substantia nigra. That part of the brain is functionally connected with other cluster of neurons, and they all sit deep into the central part of the brain. They're called basal ganglia. It's very nicely depicted here. So you can just see it looks like a pit of an avocado. So right in the center of the brain with functional connectivity throughout the brain. The main chemical problem in the brain, as you may have guessed, and you probably already know, is that there is a deficiency of dopamine in the brains of Parkinson's patients. The dopamine lives in harmony with acetylcholine in the basal ganglia of the patient's brains. And both of these chemicals, they balance each other out. So if there is an underactivity of one of the chemicals, then it causes overactivity of the other one. In Parkinson's disease, there is an underactivity or deficiency of dopamine that causes overactivity or overtransmission in the acetylcholine circuit. And both of these problems are believed to underlie the whole host of symptoms that we see in Parkinson's disease. So now that you know that in a very simplified fashion, I explained that Parkinson's disease is caused by a chemical imbalance in the brain. So the best way to improve the symptoms of the disease would be to restore this balance to as best possible. And for that, we use medications. So medications are the mainstay of treatment in Parkinson's. And I'm emphasizing that because a whole lot of patients have heard about surgical therapies, and there are some other ancillary therapies that are out there. and they just get confused as to what is the fundamental way to manage the disease. The fundamental way to manage the disease is to try to correct the chemical imbalance, and for which medications are the number one choice. Okay, this slide is not just for the entertainment purposes. It is actually to emphasize the fact that there are so many medications that are out there for Parkinson's. A lot of them are repackaging of the older medication, levodopa, but nevertheless, the combination therapies that are out there. And managing these medications can be very overwhelming for a lot of the patients and their care providers. And in my practice, I've seen that some of the patients are just truly frustrated by these. And for some, they're just downright scared. So I think the goal of the talk today is to simplify this challenge for the patients and the care providers, and to go over the rules of navigation with respect to these medications so that you could optimize the therapy for your loved one or for yourself. Some points to remember: medications in Parkinson's disease are not a cure, because we talked about progressive cell death in Parkinson's. There is no treatment or medication that is out there that can reverse it. So medications at the moment are used for symptomatic management or for symptom control. They are usually used in combination, and all Parkinson's disease medications that are out there are generally useful for all motor symptoms, although it can vary between patient to patient depending on the uniqueness of each patient. So as I said, that there are a whole host of medications that come in different shapes, color, and sizes. And in order for you to understand which ones are best for you, of course, you have to consult with your doctor, and they can pick the ones that's the right combination for you. But they all have the same function. What they're trying to do, these medications, is to restore this imbalance that exists in the brains of Parkinson's patients that we just talked about. So there is a deficiency of dopamine and overactivity of acetylcholine. I deliberately didn't mention the glutamate because it makes the process a little bit more complicated, but nevertheless, glutamate is also one of the neurotransmitters that is out there in the basal ganglia, and it also is it kind of partners with acetylcholine, so it's also overactive. So all of these medications are trying to balance these two chemicals or three chemicals out so that most of these symptoms that are a reflection of this imbalance get better. So the basic therapeutic pharmacology of Parkinson's disease medications is to do one or two of these things, or both. One is to either increase the dopamine activity, or to reduce the acetylcholine activity, or ideally to address both. So the medications that we use in order to replace or boost the dopaminergic function in the brains of Parkinson's patients, they belong to two major groups. The first group is the levodopa group, which is the gold standard for treatment of Parkinson's. It's a precursor of dopamine. It's taken in by the body and it's changed into dopamine in the brain, and then it's picked up by the relevant neural cells in the striatum or the basal ganglia, and then it is used by the brain to mitigate the symptoms of Parkinson's. Some of the formulations that are out there are very well known to the patients: carbidopa, levodopa, immediate release, long-acting, Parcopa, which is orally disintegrating form, or Rytary, which is a capsule and it has short-acting component and a long-acting component in order to give patients a smoother response, or Diopa, which is an intestinal gel, and it is introduced directly in the small intestine, but it nevertheless does the same thing as any other levodopa formulation. The other group is the dopamine agonists. So these are the medications that don't convert into dopamine in the body or in the brain. but they actually latch on to the same receptors or the controller sites in the brain where the dopamine action happens. So they mimic the action of dopamine in the brain, and hence they also relieve your symptoms or the symptoms of Parkinson's disease. They are generally longer acting because all of these enzyme systems that we're going to be talking about in a few minutes, they don't act on these medications, so they survive for longer duration. But the effect overall is a little bit muted than what you could get from the levodopa formulations. So some of them I'm sure are pretty familiar to you: properanol, pramipexole, retigotone, which is available in the patch formulation, and apomorphine that is available as subcutaneous, either injection or infusion. Okay, so the other class of medications that are commonly used in Parkinson's disease are helpers of levodopa or protectors of levodopa. So one of the challenges that we have to face when we introduce levodopa in the bodies of Parkinson's disease patients is that there are internal systems in your body that attack these foreign agents. So there are enzyme systems that target the levodopa and they just get ready to break it down. And if they do so, or if they are left unchecked, then a patient will have to take levodopa at a very frequent intervals in order to maintain the dopamine concentrations in the brain. So in order to allow the levodopa to survive the passage from the gut to the blood until it gets to the blood-brain barrier, where it's picked up and converted into dopamine in the brain, we have to protect levodopa in this journey to the brain. And some of the medications that are used for that purpose, one of them is already combined with levodopa, which is carbidopa. That carbidopa is also a carrier or a helper or a protector that blocks one of the enzyme systems. But COMT is the other enzyme system that needs to be inhibited. And two medications that we have out there to help with that is entacapone and opicapone. Entacapone is quite well known. Opicapone was FDA approved, I think, in 2016. So it's a relatively newer one. There was an older one, which was called talcapone, but that had to be removed from the market. It was very effective and longer acting than entacapone, but it had liver toxicity, so it had to be removed from the market. The next group of enzymes that are relevant here are MAO-B or monoamine oxidase group of enzymes that can also break down all of the various different neurotransmitters, and amongst them is dopamine. So MAO-B is more selective for dopamine, and MAO-B inhibitors are used in combination with levodopa formulations and sometimes alone, because your body makes your own dopamine. So if you allow your own dopamine to survive longer, that's a strategy that we employ in patients who are early in the disease. Their symptoms are not that pronounced, and we like to just give them a simpler regimen that they can be put on just MAO-B inhibitors, where their own internal dopamine is protected and allowed to live for longer duration in the brain, and so their symptoms could be mitigated. Some of the choices that are out there are ursodeline, selegiline, and sofenamide. Okay, so the next group of medications that attack the other chemical problem in the brains of Parkinson's patients, which is the overactivity of acetylcholine, are the acetylcholine blockers or anticholinergic medications, and they include trihexyphenidyl, marketed as Artane, or benzaprine, and brand name Cogentin. I'm taking the brand names here because for some patients, they're more familiar with the brand names than the generics. So just to make this talk a little bit easier on them, I'm not affiliated with any of these companies at all. Just a little disclaimer here. So these medications can actually be very helpful in some of the symptoms of Parkinson's, especially tremors, slowness, stiffness, walking problems, especially in younger patients, because they do come with a set of side effects. So the problem arises because acetylcholine is also used by the brain for memory processing. So if you try to block that chemical, you can practically cause some memory problems in patients. This chemical is also used for saliva production, for production of tears in the eyes. So dry mouth and dry eyes can be an issue. And these side effects are not very well tolerated if the patient is older and they're already having some memory problems. They're already having dry eye issues. So we have to use these medications. There are several other side effects which I'm not going over right now, but so they're not very popular in older patients, but for younger patients, they certainly do hold some promise in improving some of their symptoms. So these are the medications that have more than one action. So it's just not that they act on one chemical and that's all they do. And a couple of them you can identify, we just talked about them, rasagiline and selegiline, as being MAO-B inhibitors. But these two medications are also believed to have some neuroprotective effect. It's not entirely clear as to how they do that. Some of the theories are that they block the breakdown of so many chemicals in the brain, so there's less oxidative stress when we use it, and that may protect the neural cells. It's not thoroughly confirmed, but nevertheless, it is something attributed to them. Amantadine is a very old medication for Parkinson's, and it's a very good medication. It has three-pronged action in Parkinson's. It not only boosts the dopaminergic activity, but it also has anticholinergic functions, and it also has anti-glutaminergic functions. So you remember I mentioned early on that there are two primary chemical abnormalities. One is the dopamine related, the other one is acetylcholine related, but there's also a glutamate related issue, which we didn't talk at length, but nevertheless, this particular medication can address all three of them. So why is that not the premier medication for Parkinson's? It's because the effects are not as robust. So they do happen, and it's a good medication as an add-on. And sometimes in the early stages of the disease, it could be the sole medication that can be used. But because of its anticholinergic actions, it has some of those side effects that I talked about with respect to other anticholinergic medications, that it can also cause some memory problems and confusions and maybe hallucinations. But nevertheless, it still remains one of the strongest medications that we use in Parkinson's, primarily to manage the dyskinesia in Parkinson's patients. And as you know, that is a side effect. These are excessive movements that can be caused after a few years of use of levodopa. But amantadine tackles them very well, but nevertheless, it has other advantages that I just talked about. So safinamide is, again, I had mentioned that earlier, that is one of the most recently approved MAO-B inhibitors. It's a reversible inhibitor, and it also has anti-glutaminergic properties. So it has a more robust action in terms of perhaps improving the neural cell environment in the brains of Parkinson's patients. So that's why I kind of mentioned it again here, and that it prolongs the action of dopamine in the brain and can also have an antioxidative effect. So with all of these medication choices, the various classes of medications that are available out there, what are the biggest challenges for a patient? And of course, you can add to this list, but in my opinion and what I have seen, I think it's very important for a patient to understand their particular therapy, to know what are they taking and really why are they taking it, and how to properly take it, what to combine with what and when to take it. And then what to expect from the individual components of the therapy. As I mentioned, there are various components in most patients. So what do you think are the challenges for the patient, for the physician? So, not surprisingly, we have the exact same challenges. we want to make sure that we pick the right combination for you. And we have to make sure that you understand that combination, that why did we pick that for you? And then we have to make sure that you understand how to properly take them. And it is our responsibility to make sure that you understand what to expect from the individual component. So we have the same challenges. And what we try to do is we try to do our part in the first session, and perhaps we repeat it in the other sessions. But we also want the patients to understand that if any of these components is not clear to them, then it really is becomes their responsibility too to go back to their physician and try to clarify some of that from them again. Okay, so actually what I wanted to do here was, I don't know if we could do that or not, but I'll try that. One of the things that you must have noticed that I'm emphasizing is that you should know your therapy, which means that you should know your medications, at least early to mid stages of Parkinson's disease. Most patients should know the names of the medications that they're taking for Parkinson's, and they should be able to recognize them. And why is that important? Because as the disease advances, your doses changed and the color, shape, and size of the tablets generally changes, sometimes significantly so, and sometimes not very significantly. But you need to have the clues to be able to always select the correct dose, because you'll have the older pills laying at home, and we don't want you getting confused and taking the wrong dosage in combination with the wrong one. So it's important for you to just take your time and look at your pills maybe, a few times and learn which one is what. So I was going to just do a little quiz with everyone if that's possible. If not, then okay. So I want you guys to take a look at this pill. It's one of the most commonly used pills for Parkinson's disease management. And I just wanted somebody to tell me what it is. Okay. Well,
Yes. Open up
Yeah.
your chat. Can I guess cinnamon only because you said it's one of the most common?
Yes, you get the first prize. Oh, it
Yay.
is. Yes, you do. Well, absolutely, it is. But it is 25-250. So the 25-250 formulation is light blue and round. And I started off with that because most patients, they graduate onto this pretty quickly. Although the most common one is this one. So this one is the 25-100, and most patients are started off on 25-100. This was like the standard image of this pill for the longest time. Now I know that there's some companies who are making it the generic formulation, and it could actually be white, but nevertheless, that was the standard color of this pill. So now see, we got another blue one, and that is also carbidopa levodopa. So how would we distinguish that from the first one? Well, this is 10-100. We don't normally use it very much. It is an add-on to the therapy in general, because the carbidopa component of that is just 10. And the recent, well, not so recent research has shown that if you have to start the cinnamon preparation and you start off with taking 1 tablet of this, then this particular component is too low to protect this component, which means that you need at least 37.5 milligram of carbidopa to protect the 100. Then you'll say, well, oftentimes you're started off with 1 tablet of 25-100 3 times a day. Well, that is true, but the total carbidopa dosing then is 75 milligrams, and it lasts longer than the duration of the levodopa, so it crosses over to the next tablet, so you're good. But if you start off with this pill and you are taking that one 3 times a day, then that is definitely not sufficient. But see, the way to distinguish is the imprint on it, okay? So you may have an imprint on the 25-250, which is going to be different, 654 versus this one. So, so it is important for you to look at the tablets very closely. And that also keeps your brain sharp. Because, and trust me, those patients do way better if they're invested in their medications, they know what they're taking, and they feel that they're empowered to manage their Parkinson's better. Okay. So what is that? That is the orally disintegrating form of carbidopa-levodopa. We don't use that often. It's significantly more expensive, but it is for patients who have problems swallowing pills. They want something to dissolve in their mouth, but some of the medication stays in the mouth, so it could be a bit of a problem. And if that is an issue, you can always crush U-25-100 too, and you can put it right in the center of your tongue and take it with some water, and you won't have that problem. But nevertheless, this is available. It's also yellow, but it has a completely different imprint on it. Okay, now that is the wonder formulation of carbidopa-levodopa, if I may say so. It is Rytary. I say that because everyone remembers it from with Rytary. It comes in different increments. These are capsules, and they have beads, small beads of fast-acting and long-acting carbidopa-levodopa. And as you graduated from the lower dose to higher dose, you can see how the color of the capsules is changing. So be mindful of the color of the capsule, because several things can happen. One is that your doctor may make a change, so now you have new color capsules. So you need to take the right ones. Or let's say the pharmacy made a mistake and they sent you the wrong color capsules. If you're familiar with your color of your capsule, you would know immediately that that is not what you're supposed to be taking. So you have to be very in tune with your medications. Remember the colors, they're not very difficult to do, but that would allow you to always take your medication the right dose every time. Okay. So this one, very popular one, has been out there and says the name right on the pill. So it's entacapone, 200 milligrams. It's a very prominent brownish orange oval pill. There's no other oval brownish orange pill for Parkinson's. So if you have that, now again, I say this with the generic manufacturer, sometimes they do change the color, but this is the classic color for it. Now, these are the different tablets, various different strengths of proparanol. You can see that 0.25 looks different than 1 milligram, 0.5 milligram. And the idea is for you to be able to distinguish and immediately can recognize that whether this is your strength or it's not the strength that you're taking, you should be taking. Now the pramiprazole, again, you can see a slight change in the tablets. They're all white, but the 0.5 is bigger than 0.25, and the 0.125 is a round tablet. This is your Sagilene for the smaller strength. It is R1 for the bigger strength. It's R2. So there's some clues on the pills that, as I said, will help you remember. So these are the Sagilene capsules, very kind of bland, whitish, or just muted colors. And I say that because there's another capsule that's coming in a couple minutes that is very vividly colored. So this particular one is Sagilene. Sagilene also comes in the tablet formulation and an orally dissolving formulation. So this is sulfonamide, and 50 milligrams says 50 on it, and 100 milligrams says 100 on it. Very distinct color, a bit similar to entacapone, but the shape is distinctly different. So not very many patients are on it, but nevertheless, if you're on it, you should look at the pill and should be immediately able to tell that, okay, well, that's sulfonamide that I'm supposed to be taking. This is the mantidine. They are the most vividly colored capsules that are out there, yellow or red. And trust me, these are the ones that the patients never make a mistake. They always know whether they're taking it or not taking it, because the color is so distinguished that most other formulations or other medications that they're taking for other diseases or for Parkinson's, they don't overlap with this color scheme. Okay, so let's kind of go back to medication combination and sort of kind of try and put everything together that we've been talking about. So medication combinations are often used in Parkinson's. Even if you are on carbidopa, levodopa alone, it is a medication combination where carbidopa is being combined with levodopa. So why do we use it? The whole idea behind that is to either intensify the effect of, let's say, dopamine, or to prolong it, or both, or to give you a multi-pronged action, which means that address the dopamine problem, address the acetylcholine problem, and the glutamate problem. If you think that that is needed in a particular patient, then more than one medication will be used. So two is generally better than one in Parkinson's. So as I said, even if you are on this carbidopa levodopa, you are on two rather than just one. So the most popular medication combinations that we use are a combination of carbidopa levodopa with COMT inhibitors, either entacapone or capapone. And the idea here is to protect the levodopa, to increase the duration of levodopa, so that you don't have to take the medication very, very frequently throughout the day. Now, we can achieve the same effect by combining carbidopa-levodopa with selegiline, rasagiline, or sphingomide. As you know, that these medications also have some neuroprotective effect, and they are taken less often, like rasagiline and sphingomide are only taken once a day. Selegiline can be taken up to 2 times a day, as opposed to entacapone that is taken with every pill of carbidopa-levodopa. Now, they're not equal. The effect is, and because you can always argue that, well, why do we need to do that if we can do this? Because this is neuroprotective plus only taking once a day or twice a day. It's because some patients do better on COMT inhibitors. They get more longer duration of levodopa effect with COMT inhibitor than they would do with an MNO B inhibitor. And sometimes we have to use both. So that would be the short answer to that question if somebody had that question. But I would have, if I were you, I would have that question. Okay, the other combination that is very commonly used is carbidopa levodopa with amantadine. And as I mentioned to you, that it's the most common reason is because after a few years of levodopa therapy, the patient starts to develop dyskinesia, and which is excessive movement. So they're able to function, but their body is moving too much. In order to reduce the dyskinesia, we use amantadine. Amantadine, as I mentioned to you before, can also be used in younger patients if they have tremor that is not adequately controlled with carbidopa-levodopa, then amantadine can help. Or if they have stiffness that is not ideally controlled with carbidopa-levodopa, then amantadine can help with that too. The other combinations are combining carbidopa-levodopa with dopamine agonists. It could be rotigotone patch or reparenol or pramipexole. And the idea is, again, to reduce these on and off fluctuations, just increasing your on time, reducing the off time. There are certain symptoms, for example, restless legs. Some patients have that problem in the evening or at nighttime. So your doctor may just keep you on carbidopa-levodopa during the day, but may add the reparenol or pramipexole in the evening to try to improve that. Or you may have a condition called REM sleep behavior disorder, in which you are, the patient, has vivid dreams and they fight a lot in their dreams. Dopamine agonists can be helpful for that. So these could be given in combination with your other medications at nighttime so that that particular symptom could be addressed. Along with that, your Parkinson's symptoms at night, which is stiffness, difficulty turning over in bed, and some of the light tremor that emerges in the lighter stages of sleep could also be addressed. So those were the medications that are available right now. Those combinations we are currently using. But there's a lot more in the pipeline. If somebody wants to take a little glimpse at what's out there, then they can go to I know that this is a very busy slide and you may not be able to read all of it. But I was just looking and exploring. So on clinicaltrials.gov, if you're interested, you can go to that site. You can put in the condition Parkinson's disease. You can also type in interventional study, which would act, because there are a lot of studies on Parkinson's. Some of them are just exercise and meditation and things like that. So if you want to look specifically for studies that are testing various different medications, then you'll have to put in interventional. And then you'll see that there are two types of studies that are out there. One are looking at therapies to improve symptoms without changing the course of the disease, and they're called symptomatic therapies. They're looking at newer formulations of levodopa that could last even longer, that could have less side effects. There are levodopa infusions that are being tested. There is apomorphine subcutaneous infusion that FDA over here has not completely cleared yet. There are other newer dopaminergic medications that are being tested. There are non-dopaminergic medications that are being tested that are looking at other chemical changes in the brains of Parkinson's patients. Some of them are attributed to non-motor symptoms like depression and sleep problems, or problems with anxiety and freezing of date, for example. So there are other chemicals that are being implicated in that, and some of those therapies are looking at that, like adrenergic, cholinergic, NMDA, serotonergic, and so on. Then there are therapies to modify the gut flora, like how to change the microbiome. They're being looked at. Antioxidants are looked at. And of course, the most popular one, which is stem cell therapies, are, of course, going through phase 1 trials, successful phase 1 trials for some. Phase 1 only looks at the safety of stem cell transplantation. Then there's a whole host of others that are looking to change the course of the disease. That's where we want to be. We want a cure. So, which means that, if we could find one where this cell death could be stopped or slowed, then they would be called disease-modifying therapies. So anti-inflammatory therapies, antioxidant therapies, some of the stem cell therapies that produce neurotrophic factors, energy and mitochondrial-based therapies, gene therapies, gene modification therapies, neurotrophic factors, and microbiome, again, can also be on the disease-modifying side. Or those that target alpha-synuclein, which is one of the waste proteins, modified version of the waste protein that is out there in the brains of patients with Parkinson's. They're all being looked at. So there's hope for the future, and we're all kind of waiting along with you to see what comes up and what adds to our toolkit here. So, so whatever is available right now, I mean, how can we best use it? How can we make sure that we get the most out of our medication regimen? So some of the tips that I can give you is, again, know your medication. Trust me, it makes a huge difference. If you know which particular medication is being given to you for what particular purpose, then you would be able to best use that medication, because you are with your body 24/7. Your doctor is not. And your body can change, your disease manifestations can change from minute to minute, hour to hour, day to day. And if your doctor and you are working together, and they give you some leverage. So we don't really set patients on set schedules. If we think that the patient has the cognitive ability to be flexible, we tell them that you can do plus minus 30 minutes or with this medication, or 40 minutes, or change it this way if you feel that your body is behaving this way. So know your medications, do these discussions with your doctors, and empower yourself. So try to stay on the schedule. Now, what do I mean by that? If there is a schedule that is set by your doctor initially, then you can try that schedule out and see how that goes, which means that if you're told to take the medication every 4 to 5 hours, and you feel that the medication lasts for 4 or 5 hours and that schedule works for you, then that's great. But if you think that the medication is wearing off in 4 hours, or it lasts up to 6 hours, then you have to convey to your doctor and you can reset your schedule. But whatever schedule works for you, once you have clarified that for yourself, please try to stay on it. And why is that important? It's because you're trying to replace the chemicals in the brain that your brain has a deficiency of, which means that once it consumes that chemical, it is waiting for it to be brought back to it so that it could continue to function. It's like putting gas in the car, just 1 gallon for like 50 miles. But before the 50 miles are over, I'm talking about the hybrids because I think the usual vehicle won't go 50 miles. So before that happens, you have to put the gas again in your car if you want your car to keep moving. Otherwise, it's going to stop, right? So you don't want to get to that point where, okay, now we are stuck and now we have to restart, because restarting even a car is going to be a problem. So you don't want to get to that point. You want to make sure that you keep this thing going, stay on the schedule so that the levels of dopamine in the brain are fairly steady so that you keep moving or at least keep managing your symptoms as best as you can throughout the day. So this protein and levodopa, that's the third point here, is I'm sure you all have heard that a million times before, but I would mention it again, and so that you understand, and maybe you already do, but why is it that we don't want high protein and levodopa together? It's because levodopa and protein, they compete with each other in absorption from the gut. That's the first issue. So if you have a lot of protein breakdown molecules, amino acids, and you have levodopa sitting together, then there are only so many transporters or carriers in the gut wall to pick them up and deliver them to the blood. So you don't want levodopa to have that challenge that there's so much competition that not a lot of that medication is able to pass through gut to get into your blood. So let's say it makes it to the blood, and along with the levodopa, there are a lot of amino acids that you just had a big steak, and all those amino acids are in the blood. So even at the blood-brain barrier level, even at the brain level, you get to have the same competition, because some of that is trying to get into your brain, the protein and the levodopa. So then you have blockage both at the gut level and you have blockage at the brain level. And there could be other mechanisms that we are not aware of right now, but we have noticed that if you combine it together, you have less bioavailability or less dopamine concentrations in your brain, and your disease does not do very well. So it's not like a dangerous interaction, because some patients just think that, oh my God, I just ate and I forgot and I took my carbidopa with it. So maybe I'm going to have a very serious adverse event. That's not what's going to happen. There's no adverse event related to that. It's just that you're not going to be on for longer period of time, or you may not turn on at all. So try taking your levodopa formulations at least 45 minutes before. Give your pill at least 45 minutes. If you can give an hour, it's nothing better than that, but try to give at least 45 minutes. And if you have forgotten or you couldn't do it, then don't miss the pill. Just take it, even if it is 5 minutes before the meal. One of the things that we always talk to our patients about is that if you think that your lifestyle is like that it can happen more than once in a day, or then we adjust that dose of levodopa for you. So we give you a little bit more dose of levodopa so that you have a little bigger sort of number of molecules to compete against the protein. So that can also be done. So don't skip your dose, but do try to take it an hour before a high protein meal. But if you're having a salad, if you're having a non-protein something, a salad, fruits, crackers, and you can take it with levodopa. That's not a problem. The other point to remember is that in this disease, your medications will be in flux. They will be changed. Some will be increased, some will be decreased by your doctor. If they forget to tell you, or if they tell you and you've forgotten, just remember this rule. You're going to go down slow and you're going to go up slow. Because these medications, they have profound effects on your brain and the rest of your body. You don't want to just stop it suddenly or go high too fast, because then you can have significant side effects. The other point to remember is anytime any other doctor, a cardiologist, a nephrologist, a pulmonologist, or your general doctor adds a new medication, or you start taking a herbal product that you just saw the advertisement on TV, or you decided to, change your diet or add some kind of a food supplement, then please do discuss it with your neurologist because that might be very relevant to your Parkinson's medication regimen. It may interfere with it, boost the effect of it, inactivate the medication, or so on. So we do need to be kept in the loop if there are changes in your medications. So don't forget to discuss that. Okay. So the most important thing in this, well, they're all important, but staying on the schedule is by far the most important thing that you have to do. So try to not miss doses and try to discuss any kind of scheduling issues or scheduling problems with your doctor so that you could optimize the intake and keep everything flowing really well. So I know that everything is kind of overwhelming. There are a lot of medication choices out there, and you have to get to know them. But trust me, if you learn your medications and you work with your doctor and you work with your caregiver, you can master it and you can do a really good job to make the most out of your medication regimen and do well. So best of luck to all of you. And thank you so very much to listening and paying attention here. I can conclude here and I can take questions. Okay, thank you very much.
Thank you. We do have some questions. The first, kind of two are along the same line. What is the role of extended release carbidopa? And someone asked, what's the difference between the carbidopa levodopa and the carbidopa levodopa extended release?
Okay, very good question. So carbidopa levodopa, if it is not produced in a way where the molecules are made to last longer, then the immediate release formulation has very relatively short turnover time. So it means that in the initial stages of the disease, the medication can last for 4 to 5 hours. Then as the disease advances, the body's internal systems to break it down start to act faster, then it may last for only 2 hours in certain patients. The extended release formulations have special chemicals that are added to carbidopa levodopa so that they sustain the amount of levodopa that is released from either the capsule or the pill in the gut. And they also allow the same levodopa to stay in the blood to be picked up by the brain for longer periods of time. So it's the main difference is the ability of these two to stay in the brains or the blood of the patient for either a shorter duration or a longer duration. I don't know if that clarified that for you. But as a net result, the efficacy of the medication is not different. It's still the same medication. But the extended release medications, with the exception of Rytary, which is created differently, they generally release small amount of medication, those pills, over an extended duration of time. So you may not get the robust effect that you may get with a short-acting medication. So sometimes short-acting is combined with long-acting so that you get the immediate kick that you're looking for, and then it kind of, the long-acting pulls it along for the next several hours.
We have a question. Does lithium affect dopamine at all? Does it interfere with dopamine reaching the brain or anything?
So lithium is a very unique molecule, and it can also cause tremor and some other side effects that you may, if lithium is added to your medication regimen while you're being treated for Parkinson's, you may notice that your tremor is worse or your Parkinson's is worse. It is because of some of the unique things that lithium does to the brain. So it may not be a contraindication to combine them, but it just is that some of these symptoms can get worse, and you do need to talk to your neurologist about that.
Okay. And can you talk a little bit about the neuro patches?
Oh, so the Tigatone patch. So this is a dopamine agonist. And as I was telling you, the dopamine agonists are artificially produce medications that mimic the action of dopamine in the brains of Parkinson's patients. So they modulate, they kind of trigger the same receptors, and they are available in different formulations. So a drug maker can market a chemical differently depending on how they think they can increase the sales or what would be more convenient for the patient. So this particular patch has what we know is a dopamine agonist, which is not very different than pramipexole or ropinirole. But it's just that it's embedded in a patch that you apply to yourself, and it's good for 24 hours. So you don't have to really take the medication in every 6 hours or 8 hours. But one of the problems with patches is that uh, the absorption through skin can fluctuate. So the steady state that you achieve sometimes by taking things orally it's not always achieved with the patch. But for most patients, this is an add-on therapy, and they tend to do just fine because if the absorption is not so good, some of the other medication that they're taking is going to just fill up the gap. But it's a convenient way of taking a dopamine agonist if your doctor thinks that dopamine agonist is something that is suitable for you. But there's nothing else that is unique about it than with the exception that's available in a patch formulation.
And does very hot weather affect the medications or make them less effective?
Oh, what a fantastic question. This is something that we tell our patients all the time that please do not leave your medicines in your cars, even in spring weather or fall, because yes, extremes of temperatures can deactivate not just these but pretty much all the medications or reduce their efficacy. So try to maintain the temperature that is designated. Actually, there is whenever you receive whichever medication that you receive, there is an information package in there that will tell you what would be the ideal temperature to keep that capsule or a patch or a, there are different things out there for Parkinson's or a tablet. But as a general rule, if you can just keep your medications at room temperature, whatever is convenient for you, they'll be fine. But some people do put them in the refrigerator, and for certain medications, that's fine too, provided it is okayed by the manufacturer's, specs. But please do not expose them to extremes of temperature, especially hot temperature. Yes, they will inactivate the medications.
And then, if you need the medication for other symptoms, such as insomnia or anxiety, what is the best method to determine which medication works best and doesn't cause other symptoms like constipation, for example?
Okay, very good question. And you must have noticed that I only talked about medications that primarily act on the motor symptom in today's talk. Some of these do have non-motor effects. So because the majority of the non-motor symptoms in Parkinson's patients are managed by medications that are out there for those symptoms separately, like sleep disorders, depression, anxiety, and cognition, and so on. So the selection of a medication for a specific non-motor symptom that you have has to be made by your neurologist based on your unique features, like what other medical problems do you have, what other medications do you take, what kind of problem that we're dealing with. Is it that you can't fall asleep, or is it that you fall asleep but you just wake up? So these both are called insomnia, sleep initiation insomnia or sleep maintenance insomnia. So these choices are determined by your doctor based on your overall, the features of your medical um, profile in general. But it is important to read the side effects, and I'm glad that you're in tune with that. Yes, those some of the medications that just randomly picked in a hurry by whoever can actually lead to some other side effects, and they may not go very well with your Parkinson's medication. So it's important for you to ask all the right questions when you are with your neurologist, and go over the potential side effects that are listed all in the information brochure that you get with the medication. So if you start to get any of those side effects, then discuss with your neurologist. One thing I want to tell you is that dopamine formulations actually, if they're given in the right dose and at the right time at night, can actually help with sleep in a lot of patients. So some patients are not taking enough at bedtime, and if they're boosted with those at night, they can sleep better. Melatonin is a pill that is used for short durations. It's not to be taken forever and ever, especially if you are noted to have some features of melatonin deficiency. Then melatonin can be useful as an add-on without having some of the other side effects. For anxiety, again, dopamine optimization of the Parkinson's medication schedule sometimes help with a lot of these symptoms. So the first step that we do is to look to see whether this is one of the off symptoms, that are you actually wearing off and not having other symptoms, which getting anxious or not able to sleep or relax. So the first goal is to optimize the PV medication themselves, and then to use the add-ons that will kind of go well with it. But that's your neurologist and your primary care doctor working together on that.
Uh, the gentleman clarified. He meant the effect of hot weather on like Parkinson's, not so much like how the medication is stored, but like, do you notice like, and I understand
Oh,
that some people have told me that they don't do as well in the cold weather. It like increases their stiffness. Have you noticed, have people said anything to you, especially with Houston having some power outages and maybe not having their air conditioning?
yeah, very good. Excellent. Okay. So, yes, that's what we were just informally talking about. The weather effect on Parkinson's. Absolutely. Now, just imagine a normal person who does not have Parkinson's. Do you think the weather has an effect on an individual person? The answer is yes, right? Some people are tolerate hot weathers better, and some people tolerate cold weather better. And that's why they choose the geography usually, if they don't have other limitations, to live either in Florida or in Wisconsin, um, based on what they like. So everyone is unique. You have to understand that this is basic human physiology. Some people tolerate certain weathers better than the others. Everything is exaggerated if you have a medical illness like Parkinson's, or because in Parkinson's, there is an abnormality of the autonomic nervous system, which means that there could be an abnormality in sweat production. There's an abnormality in blood vessel flow changes. So in hot weather, you have what we call dilation of the blood vessels that can drop your blood pressure. And when that happens, some Parkinson's patients are already dropping their blood pressure because it's part of the disease. So the blood pressure drop can be more pronounced in them. So they may feel low in energy. They may feel that their tremor is worse. They are shuffling more. They feel dizzy. They have low energy. So all of these symptoms signify that you need to A, hydrate yourself well, protect yourself from the weather, and then also check your blood pressure and other parameters to see whether these can be addressed separately in order to make you feel better. But you are right. There are some patients who do not tolerate hot weather, extremes of weather, very well. And for them, obviously, there should be strategies in place beforehand for them to know what to do, and what to avoid.
Well, we are out of time. So thank you so much, Dr. Sarwar, for taking the time to speak with our community today. You did a wonderful job. Here at PMD Alliance, we have a tradition, our wave of gratitude. Thank you so much. Thanks to everybody for being here today. And thank you, Dr. Sarwar, for giving us sharing with us your energy, your time, and your intelligence, really.
Oh, it was my pleasure. I really enjoyed it. And I really think it's such an important topic. And I really want to thank you all for giving me this opportunity and being such a phenomenal support even before the meeting, during the meeting, and of course with the sweet gratitude that you expressed at the end of the meeting. So thanks a lot, and I look forward to seeing you perhaps sometime in the future too.
Definitely. Thank you, everyone. Have a great evening. Good rest of your day.